The key to posterior scoping is always knowing where your FHL is here. And as we push this in, we can see it's actually a loose body in here. And this is probably an os trigonum that is detached, which is very common. So resection of os trigonum, which used to be exclusively an open procedure, we now do in office. So we can remove this in office, and we'll show you how in one moment. So we're just going to, first of all, using the 3-5 shaver, with our always being careful to have the back of the shaver pushing against the FHL, which you can see is running along there. We're cleaning up all of that scar tissue. In a nice paper again from one of our former fellows, we could see that every single time there was an os trigonum, there was an associated FHL tenosynovitis, and we'll really look down that tendon now in a moment once we clean it all out. But you can see all of this cicatrized scar tissue around here that is all causing impingement on the FHL tendon. So we're going to clean all that up, being aware all the time on the medial side of this is the neurovascular bundle. So we want to be careful of that. And we need to be careful a little bit also that we don't injure the posterior facet of the subtalar joint, which is right in here. But we can be fairly aggressive pushing down that channel so that it'll really open up. And there you can see we've really opened up the FHL. So this, as you know, is common in soccer players and dancers and so forth, where they get an FHL tenosynovitis. And you can see we're cleaning all of that up. And the shaver here, this is a 3.5 shaver, and it's just about as aggressive as you need down here. And anything more aggressive, you could get yourself into trouble fairly easy. But the idea is keeping this always with the back of this shaver pushing against the tendon to avoid any iatrogenic injury. So we've cleared that away nicely. And now we'll try and drive down here. Sometimes you can, when you move this, you can see that there's longitudinal striations of the tendon. That's absolutely normal. When you see transverse striations, you know that's where the tendon has been impinged in some way. So we're looking all the way down there. We'll try and come around the other side of the tendon now. And then we'll come around the front of the tendon down here, and you can then dive right down. And the beauty, of course, of the 2.0 needle scope, as you can see, there's flexibility in this. So you can really drive this all the way down as it starts to turn around the medial mal. And you can see quite clearly, if you look at the quality of this image, you can really see almost the morphology of that tendon is absolutely perfect as it runs down there. So that's really what we do for FHL tenosynovitis, cleaning everything up, making sure that it glides nicely. And in this case, we've seen a detached os trigonum. That's often attached to the ligament, so the intermalleolar ligament is attached to it. And so we're going to look to see if we can find it. It probably came from here. Okay, so we've identified that floating os trigonum. Here it is, and this is a really elegant grasper. Again, it's just 2 millimeters. It's very, very strong, and that's holding that piece. And then we've widened our portal so that as we pull this through, it should just come out without any difficulty. And that can be done as the patient is wide awake. And of course, this is a eureka moment for them because this has been irritating them for quite some time. As we're constantly moving our hand, you can see it's starting to pop through the skin, constantly moving. And there it is. So that's this, again, all done with a 2 to 3 millimeter incision and all done in the office. And then you go back in to look at where that came from, which is typically around this area here. And we're going to use our shaver again to smooth the bed of that out, all done on the medial side. But always being aware that's our landmark, always. The FHL over here is our landmark, and we never want to go medial to that. So again, protecting it. Cleaning all that area up here. And when we started doing these, probably 20 years ago, in an operating room using a scope, we took an awful lot of this soft tissue away. And what we've learned since is the body doesn't tolerate a dead space. It will fill that in with scar tissue. So you really just need to take away what you need to take away and no more than that. So there's no point in being too aggressive here. Whatever is causing impingement or inflammation, you take that away and you leave the rest. Here you can see that as the tendon goes by this little piece of the posterior talar process, that may be causing impingement. Oftentimes you find this process, and then behind it you'll see some inflammation of the tendon. So again, constantly moving this, being careful not to damage the tendon in any way. But the important part of this is that you can really get the patient to move their tendon at this time, so they see what you're doing, and they will automatically feel that that's free by comparisons. This is a 3.0 jacketed burr. And again, the key to this is to make sure that the jacket is right up against your tendon so that there's no chance that's going to cause any injury. And then very gently, just moving it, constantly moving it away from the tendon, creating that space. And you can see how the image is constantly adjusting as I'm moving a reflective surface closer to the camera. It's adjusting constantly so that it reduces glare and gives me that nice feedback. Again, always being careful that the operational side of this is always facing laterally. You want smooth edges here, so we'll go back in with the shaver on oscillate, and you can see now how that tendon really is free. There's nothing binding it, and perhaps there was something if you look at how there's that little fusiform swelling there just adjacent to that protuberance. So that may have been a problem for this patient. And again, you go in and you just want to make sure that all of that is nice and smooth before you get the patient off the table. Typically post-operatively, these patients are just given standard pain relief medicine afterwards. They only need it for about a day or two, and we get them moving right away. There is no downtime after this procedure when it's done in office. We're not trying to regenerate or repair anything here. We just want them to move and prevent scar tissue. So we get them, they walk off the table, and they're allowed to walk that day, and they're allowed to do more activities over the next days as tolerated. So again, when we look at the outcomes of this, most patients are back to their pre-level of sporting activity after an operation like this within a couple of weeks. And that's, again, at least a month sooner than if we were to do this in an operating room. So again, an advantage. The patient buys in, they see what's going on, the recovery times are quicker, and at the end of the day, the expense is far less.